Welcome to Cardiovisual App. My name is Dr. Paul Tucker. I'm an interventional cardiologist with Texas Heart and Vascular. I'm here to talk to you today about statins. They're a very common medication used in cardiovascular disease and in the prevention of cardiovascular disease. Statins are a class of drugs that are used to lower cholesterol levels. They work on an enzyme in the liver to bring down your total cholesterol and also your LDL cholesterol in particular. To some degree, they lower triglycerides, but they do not affect HDL, which is the good cholesterol, very much. By lowering cholesterol levels, statins have been shown over many years in many trials involving hundreds of thousands of patients to reduce the risk of heart attack, stroke, and death. In fact, the risk reduction might be as high as 25 to 35%. Some of the common statins that you've probably heard of are atorvastatin, brand name Lipitor, rosuvastatin, brand name Crestor, simvastatin, brand name Zocor, pravastatin, brand name Pravachol. About the only statin that is currently not generic is pitavastatin or Livalo. Most statins are taken once a day at bedtime. Most patients will take them at bedtime because that's when your liver makes cholesterol and you want to inhibit it the most. The vast majority of patients who take statins do not have side effects. You need to be careful about what you read on the internet. Especially on Google and some of the common sites, you will see many articles talking about the multiple negative side effects of statins. But for the most part, most patients can take them without any trouble, without any side effects whatsoever. The most common side effect that we worry about or that can occur is in about 10% of patients they will develop some muscle aches or muscle soreness. In some cases it can actually be fairly severe. In really bad cases it can actually lead to muscle damage. It is measured by an enzyme in the blood called creatine kinase. In most patients who are on statin therapy, I check their CK level or creatine kinase every 6 months. And frequently, if a patient is going to have muscle aches, the CK will be elevated, but it also can be elevated even with the patient being without symptoms. Again, however, in 90% of patients, they do not have muscle aches and they never get a CK elevation. Some other side effects that are less common include diarrhea, nausea, stomach upset, headache. Some fairly uncommon side effects would include sleep problems or low platelets or other issues with your blood. There are some studies that suggest certain statins, specifically Lipitor, could maybe increase your risk of diabetes, but the actual true incidence of that is probably very low. So who is at risk for developing side effects from statins? If you take multiple medications to lower your cholesterol, that can put you at increased risk because of interactions. Females tend to have a slightly higher risk. Having a smaller body frame or being very elderly increases your risk of side effects. Drinking too much alcohol or having pre-existing kidney or liver disease can also affect the risk of getting statin side effects. Finally, patients who have some neuromuscular disorders such as muscular dystrophy, hypothyroidism, amyotrophic lateral sclerosis, these are patients who you would want to be very careful about using statins. Certainly monitor them carefully if they're going to be on them. So what do you do if you start having muscle symptoms from taking a statin? Well, the first thing is to call your doctor and let them know. In my case, if a patient calls and says their muscles are hurting, I usually stop the statin. I tell them to wait 3 or 4 weeks and let me know if the symptoms are getting better. I also usually check a CK level to see if there's any evidence of muscle damage from the drug. Again, not common to have that happen. Less than 10% of patients have myalgias, and even a lower percentage of that have an elevation in the CK level. But when it happens, the medicine should be stopped and you should see how things are looking a few weeks later. If the CK is elevated, I simply repeat the CK level in 3 or 4 weeks to see if it has come down. Frequently, I will change to a different statin. For some reason, patients do better with certain statins than others. Some statins are hydrophilic, meaning they don't cross cell membranes easily, and some examples of that would be rosuvastatin or pravastatin. Other statin drugs can cross the lipid membrane more easily, such as atorvastatin, and that one might be a little bit more likely to cause muscle aches compared to rosuvastatin. One of the non-generic statins, Livalo, is actually marketed as having a lower risk of having muscle-induced discomfort or elevated CK, and I found that to be true in my practice as well. So who should be on a statin? That's probably the most common question I get when someone comes to me with high cholesterol. Well, it is a complex question. There's a lot of different things that go into the decision. For example, do they have a family history of heart disease? If so, is it an early family history of heart disease, meaning patients having problems in their 40s or 50s that are related to your patient? Does the patient have a very bad ratio of the cholesterol? For example, is the good cholesterol, the HDL, very low and the LDL very high? That is a specific subset of patients with high cholesterol that is probably at higher risk because the HDL is felt to be protective while the LDL is damaging to the arterial wall. If a patient has multiple other risk factors, including diabetes, high blood pressure, smoking, the more of those risk factors that a patient has, the more likely I am to recommend a statin if their cholesterol is significantly elevated. Statins are also indicated for patients who have had a previous coronary or vascular event, such as a heart attack, a stroke, a stent, or a bypass. In those patients, statins are generally routinely recommended unless they have contraindications. Another common scenario in which I will prescribe a statin is if a patient comes to me and has evidence of an elevated calcium score, even though they may not have had a cardiac event. A calcium score is a CT scan that looks for plaque in your heart arteries. If it's significantly elevated, for example, over 400, and the patient has high cholesterol, then that would be a patient I would strongly consider using a statin to get their LDL under 100, preferably under 70 if possible.